Hello, I'm Mohamed Soliman, a psychiatrist at Massachusetts General Hospital and Harvard Medical School. I work at the Dauten Family Center for Bipolar Treatment Innovation together with Dr. Andrew Nierenberg and our other psychiatrist team. I wrote this paper with the doctors Sharmin, Ghaznavi, David Mischoulon, and Ted Stern. Our main message was bipolar often hides inside familiar symptoms: depression, anxiety, irritability, poor concentration, impulsivity, and disturbed sleep appear across many psychiatric conditions. The challenge does not come from recognizing the symptom, it comes from understanding the pattern around it. We therefore focused on four questions. When did the symptom begin? How long did it last? What triggered it? And did it represent a clear change from the person's baseline? That distinction matter. Poor sleep and anxiety often leaves someone exhausted. During hypomania or mania, a person may sleep only a few hours and still feel unusually energized. Racing thoughts and anxiety often loop around threat and worry. In bipolar disorder, they may become expansive, creative, and tied to multiple new plans. Another illness that resembles bipolar is ADHD, but ADHD symptoms usually persist across time, while bipolar symptoms tend to cluster into episodes. One of the most important findings involves screening. Several tools can help us detect bipolar spectrum illness, but each tool answers a slightly different question. For example, the Rapid Mood Screener, RMS, offers a practical first step in busy primary care settings. It uses only 6 items, can take up to 2 minutes, and showed strong sensitivity and specificity for bipolar 1 disorder. Another tool is the Mood Disorder Questionnaire, MDQ, which remains widely known and performs well in psychiatric settings. But its sensitivity drops substantially in community populations, and it might miss, for example, bipolar 2 disorder. The Hypomania Checklist 32 can help when we suspect subtler hypomania. It can produce more false positives. The Bipolar Spectrum Diagnostic Scale may capture softer or atypical presentations that do not fit neatly into classic mania. So we not need to ask which screening tool is best, but I think the question would be which tool best fits the clinical setting and the population we are treating. And as a note, which screening tool is best does not establish diagnosis. Screening tools help us decide when the story deserves a closer look. The paper also highlights a recurring clinical problem. Many patients with bipolar disorder first seek help during depression, not during elevated mood. In primary care populations with depression, bipolar spectrum disorders may occur in roughly 1 in 6 patients. That means we need to ask about lifetime changes in energy, sleep, activity, impulsivity, family history, and previous activation after antidepressants, not only the current depressive symptoms. The broader implication reaches beyond bipolar disorder. Psychiatric diagnosis works best when we move from isolated symptoms to patterns across time. Future research will likely combine more sensitive and specific screening with high validity, collateral history, repeated measurements, and digital tracking, especially of sleep and activity. But technology is less likely to replace the central clinical task. We still need to understand not only what symptom appears, but how it moves, what surrounds it, and how it changes the person's life. Because in psychiatry, the pattern often reveals what the symptom alone can't.